and our next speaker is going to be Dr. Mohamed Hussein from Baylor College of Medicine. And again, just a reminder, please do type your questions in and we'll try to get to those. But please, speakers, try to keep your talks limited to under 10 minutes so we can get those questions in. And please take it away, Dr. Hussein.
Okay, good morning. Can you guys hear me?
Yeah. Mm-hmm.
All right. So some peculiarities regarding COVID-19. One, children seem to be the least affected in terms of severity and possibly even frequency, which is totally counterintuitive to what we know about respiratory tract infections, where kids tend to be affected with more frequency and with greater severity than adults. Two, severity of the infection and the mortality so far seems to be affecting less developed countries more than more developed countries, which is again very counterintuitive. You would expect more burden on the less developed countries with typical infectious diseases. Three, there is big discrepancy in the severity of infection among patients who have similar clinical profile. You can have two people having the same clinical profile, one dies and the other one actually doesn't have symptoms at all. Looking into the route of transmission of the virus as a possible explanation for these peculiarities hasn't been seriously considered or looked at. We know that respiratory viral infections in generally have access to the body mainly through the nasopharynx. Ocular involvement was thought to play a less important role. However, that role hasn't been properly studied. And for the past couple of 3 weeks, we learned a lot about the relationship between the eye and COVID-19. Now we know that the virus can replicate in the tears for a long period of time. We know from one big study that 30% of patients can have ocular involvement. The majority of those that have ocular involvement would end up having severe disease. And the very interesting study that came like a week ago showed that the virus had very, very high affinity to the conjunctiva and the ocular surface, very much similar to the affinity to the epithelial lining of the respiratory tract, 100 times more than the affinity of SARS-CoV-1. So the virus loves the eye, and the eye seems to be a problem with COVID-19. And not only that the eye seems to be a problem, I think it is the problem when it comes to severe disease. Ocular involvement and immunity can explain all the peculiarities that I mentioned. The fact that children are at risk for less risk for being infected and with less severe disease can be explained by the ocular immune differences between adults and kids. Adult eyes are immune privileged organ, which means that they have less immune response or suppressed immune response, which is supposed to be something protective for the very vital organ like the eye. Kids, it's not like that. It's not an immune privileged organ. They actually have the opposite. They have strong immune responses, which may have protected kids, as I will mention in a few seconds. Another observation is what I said, the less developed countries having less mortality from that disease. And again, the eyes of people living in less developed other countries are not immune privileged, or a lot of times it's not immune privileged, less immune privileged compared to the eyes of people living in developed countries because of endemic ocular infection, which can allow more innate immune response that allows the eyes to fight infections more reliably. One common endemic ocular infection shared by most of the countries that have least for the mortality is something called trachoma. If you guys don't know what that is, it's basically a surface disease, a disease of the eye caused by chlamydia, and it's the commonest cause of blindness in less developed other countries. You can see here the map for endemic trachoma countries. It really matches the map of the less mortality from the disease. Interestingly, if you take Ethiopia and South Sudan, for example, they actually have the highest, they are the most endemic for trachoma. And these two countries have a handful of cases and they literally have zero mortality, Ethiopia and South Sudan. Another interesting point is that countries where wearing glasses is an epidemic, like the Asian border countries, seem to control the infection at faster rates and tend to have less mortality from the disease, taking like Singapore, South Korea, Taiwan, parts of China. Myopia, which is nearsightedness, is actually an epidemic there. Like in Singapore, it's 90% of people are myopic. In South Korea, it's like 75%. And going to Europe, the Germans have the highest prevalence of astigmatism and myopia. And we know that actually the Germans had less mortality compared to their neighboring border countries. So it could be that protective, wearing glasses lessens the severity of the disease. From this immunologic data and epidemiologic data, it seems that the eye is a problem and can be the problem that directs the severity of the disease. If the eye gets involved because the weak innate immune response typical for adult border eyes, the virus would replicate unchecked on the ocular blood surface, tears, and then delivers large amount of virus through the tear duct system into the nasopharynx, challenging the immunity, the natural immunity, and leading to severe disease. This is not going to happen in children because they have better immune response to their eyes. It's not going to happen in less developed or the country patients, some of them, or people, some of them, because their eyes are not immune privileged for the most part because of the trachoma. So as such, topical ocular medication may be an ideal treatment and maybe ideal prophylaxis for COVID-19. It will exert its effect on the eye, sterilize the eye, will drain through the tear duct system into the nasal cavity, and then there will be like rapid absorption of significant amount of it by the vascular nasal mucosa, and it would have a systemic effect. Cyclosporin is one medication that was found by a large study to have a strong antiviral effect against coronaviruses, specifically SARS-CoV-1. And this nice for the study. Multiple countries in Europe shared in that study, and they found that a very low micromolar non-cytotoxic concentration of cyclosporin is capable of killing SARS-CoV-1. We know we have cyclosporin as an eye drop, which is kind of fortunate. It's a drop that is used for treatment of dry eyes. It's been used safely and effectively for years. There are two concentrations of it. The Restasis is the most popular and common for the ones. This is 0.05%. We calculated the dose on this drop to be 13 folds the lethal dose for SARS-CoV-1. We have another one that just came in the market last year, which is double that dose, can be more effective. We have both FDA approved Restasis in 2003, and the Sequa, which is 0.09%, actually was approved last year, and they both have been used safely and effectively, no systemic or topical side effects whatsoever. So if there is evidence of the literature that cyclosporin actually can kill coronaviruses, specifically quoting about SARS-CoV-1, it's not really totally crazy idea to assume that it may have a similar or close effect on SARS-CoV-1. And since we have these drugs available, they are safe, no topical or systemic side effects, it may be warranted to look into the effectiveness of these drops in reducing the viral load in patients that have COVID-19, and more importantly, to use it as a prophylaxis. So in summary, the ocular pathway may be an important source of COVID-19. We now know that it's there, that the virus loves the eye, and it may be the directing force for the severity. Protective eyewear may slow down the transmission. I think this is a very important point to elaborate. And I think CDC should, based on the last studies, issue a warning about wearing contact lenses and the importance of protective eyewear. Cyclosporin, there is a big nice for the study that shows that it can have an antiviral effect against coronaviruses, and cyclosporin, drops are available and they can be a potential option for treating and a prophylaxis for COVID-19. I think, just because it's an urgent matter that we're living in right now, a potential answer for this, hypothesis, and the merit of this hypothesis can be achieved, I think, through a national or a state with a survey that looks into how patients that use this, because a lot of people actually use this drug, how these people fared compared to other people, say in an area where there is high infection rates, say like New York City, how did these people fare in terms of frequency and severity of infection compared to other people? It'd be interesting to know how they fared with that. Also, those wearing glasses, how they fared compared to those not wearing glasses, specifically in terms of severity of the disease, and also contact lenses, which I assume will be a problem. How did these patients fare compared to people that didn't use it in terms of severity of the disease? That's all what I have. Thank you.
Okay, thank you very much. We have, one question. So the question is, revisiting some of your early slides, is it true that no one has died of COVID in Middle Africa or India?
Actually, this is what I just mentioned in the slide. I mentioned that, Ethiopia and South Sudan, which are the countries that have the most, endemic for trachoma, I think one of them, Ethiopia, has zero mortality, literally zero mortality. No one died.